illustrative cases that we encountered recently. So this is a 41-year-old diabetic male complained of moderate to severe left lower quadrant pain and fever of 1-day duration. Had 2 similar episodes in the past, treated with oral ciprofloxacin and metronidazole in the past 2 years, and was told to have sigmoid diverticulitis. So the P at the ER was patient has a high BMI, class 1 obesity, febrile, normal BP, likely tachycardic, and not tachypnic. Abdomen was globular, soft, no palpable mass, but with guarding, tenderness, and palpation of the left abdomen between the left upper quadrant and left lower quadrant, extending to the plank area. ER is unremarkable. So what's your primary diagnosis and differential diagnosis? Of course, with the past history, this is a recurrent and acute attack, sigmoid colon diverticulitis. Possible differential is pyelonephritis because of the plank pain and tenderness. So what will you request? TBC, urinalysis, and particularly CT scan for imaging. So these are the results: elevated WBC, creatinine is normal, elevated HbA1c. So CT scan of the abdomen with IV contrast showed thickening of the sigmoid colon with a 5 centimeter collection of fluid. Question is, what empiric antibiotics are appropriate for this patient? First, let's classify and re-stratify the patient and the infection. So these are community-acquired intra-abdominal infection. Patient is diabetic and vital stable, no signs of sepsis of septic shock, although patient febrile and slightly tachycardic. So can we still classify this as low risk? Although there's some risk factors, but patient is ambulatory and up and about except for the fever and pain. So we can still classify this as a low risk but complicated intra-abdominal infection. PCS, during our time with Dr. Bongala, we came up with some guidelines on surgical infections and also prophylaxis, and these are guidelines to select our empiric antibiotic therapy in complicated intra-abdominal infection. Of course, the SIS guidelines also have their own recommendations for lower risk and higher risk patients, both single and combination regimens. And they also have different regimens for hospital-acquired infections. Our department of surgery in PGH also has its own treatment or antibiotic guideline for complicated intra-abdominal infection. And this is reviewed regularly and changed as necessary based on our local antibiogram. So the patient was started on ertapenem 1 gram once a day. A percutaneous CT guided drainage was done on the next day. Culture showed E. coli is BL positive, sensitive to the antibiotic being given. However, on day 5, hospital day 5, patient remained febrile, tachycardic with increasing abdominal pain and picaloid output from the pigtail catheter. A repeat CT scan showed persistent abscess cavity with communication to the colon. So there's colocutaneous fistula with persistent abscess. Antibiotic was shifted to piperacillin tazobactam. And patient was scheduled for surgery the next day. And patient did well post-operatively. So a decision was made that another intervention for source control has to be done. because the patient's clinical symptoms and imaging showed treatment failure. So this is the video of the patient or the play.